Katsouras have recently.
Sorry.
No problem. Asked to co-direct Global Grand Rounds to give Dr. Good a little space, a little time, and really appreciate his and the staff of Global Offsite Care, Michael, and also the Global Grand Rounds team, Alexa, Katie, Lauren. Thank you very much for the opportunity to help in this effort. And wish I was more technically savvy and could solve this problem you're having right now. But time will heal, I'm sure. So this week's speakers are Mr. Mr. Iyadi Francis, BSc, Assistant Director of Physiotherapy, and Ojeniwe Oji Chukwu, BMR Master of Science, Assistant Director of Physiotherapy. They're both from the Federal Medical Center of Yenagoa, if I pronounce that correctly, in the Bayelsa state of Nigeria. And their topic, as you can see from the handout, is bilateral upper limb neuropathy secondary to physical restraints at the wrist. And we'll go ahead and get started with moving through the first part of the presentation. When they're able to be back on, we'll go ahead and have them pick up where you're at, where we might be in the presentation. So, and how are we doing there, Alexa?
I think we're doing great. Thank you for that introduction, Dr. Pecchia. How are the folks over at FMC doing? Are we ready to go?
Yeah.
Great.
Yes. Yes, we are.
Tell me when to hit next, and I will move the slides for you.
Yes. Enable us to share screen.
Okay. If you would like.
Let's just co-host as well.
And to the speakers, just a reminder, welcome. Dr. Pecchia, I don't know if you saw the, we're in for the the introduction. If you could just spend a couple of, a minute or two on yourselves, an additional introduction, who you are, your, who your affiliation is, and then we'll have about 30 to 35 minutes, maybe 40, on the presentation. We'll leave about 5 minutes at the end, and we'll be done at 0900 hours Pacific time. Welcome.
Thank you. I'm Ojeniwe Ogichukwu, all right, and I'm also the Assistant Director of Physiotherapy here in FMC Yenagoa. And I'll be presenting this another colleague of mine, Francis is his name. We're going to take it in two forms. I'll take the introduction. He'll be working on the study proper. Are we good?
You know, I do think I'm having a bit of trouble hearing you. Would it be helpful maybe just to turn off your video?
Okay.
Okay, so we lost them just again. I'm gonna go ahead, share my screen one more time. hopefully this will, third time's the charm. Okay, here we are.
Okay. Alexa, I'd be glad to be the reader and kind of move ourselves through this. Is that
No
helpful?
problem. Mhm.
Okay. Yeah. I should be reasonably skilled at this as a professor and a faculty member at, or associate professor faculty member at Western U. This is part of the skill set. So let's move on through. We introduce the speakers. And Alexa, next slide. Peripheral neuropathy is a common, often distressing condition. Those of us in the room, especially adult and geriatric medicine specialists, we see this quite commonly. Prevalence in the population, I'm not sure which population that is, but about 2,400 per 100,000, 2.5%, and about 8%, I would assume, with the aged population. Restricts freedom of movement, physical activity, and normal access to the body. Physical restraint, that sounds like their terminology of limitation of movement for short periods of time by the use of devices versus chemical restraint. It's defined by the use of pharmacological agents to subdue patients. I think they're just differentiating between the use of the term restraint. Next slide.
Yes, so I do see FMC is here. Would you guys like to pick up? We just started going through your slides. Would you like to pick up maybe on this slide?
Okay, can you hear us?
Yes.
Oh, all right then. Thank you for taking the first slide. In this slide now, we can see that peripheral neuropathies are commonly seen in clinical practice. I'm sure we know that. And nerve injuries can be classified as either neuropathia, adenopathy, or neuropathy, depending on the degree of damage. For neuropathia, it can either be segmental or focal demyelination, with the axon being preserved. While for adenopathy, it's the injury is much more, and the axon in this case is divided. However, the epineuron remains intact, which allows for the regeneration of the tissues. Clinically, we can say that this has motor and sensory deficits as it presents. Neuropathy on its own is a complete division of the nerve. And in this case, complete recovery, especially the former, may not occur in this wise because there's permanent loss of function here. Next slide, please. You can go to the next slide. For epidemiology, generally, in the general population, we have about 2.4% per 100. That's about 2,400 per 100,000 individuals. And this increases with age, especially for those that are older than 55 years old. We have varying causes of various etiology. For example, we have diseases, HIV, vitamin B deficiency, cancer, diabetes, and leprosy might be indicted in this case. For drugs, we have heroin and statins. Statins, possibly in the use of antihypertensives, can be indicted here. Toxins, alcohol use, heavy metals like lead, then trauma, which could be as a result of road traffic accidents in the case of neuropathy. Traction, which is our primary concern today, has restraints as an example there. Next slide. Clinical signs and symptoms. We said that peripheral neuropathy can come up in two ways. It could affect our sensation. It could also affect motor function. Now, for sensory symptoms, we have tingling, pins and needles, numbness, tightness, burning, pain, and sensory ataxia. While for the motor symptoms, it could include muscle cramps, stiffness, weakness, and wasting of the muscles. For peripheral neuropathy, rather, we could also have autonomic dysfunction, which would affect, or which would show rather, from sweating, excessive sweating, dryness in the mouth, or dry eyes. Principles of treatments. There are basically two principles of treatment. One, controlling the underlying disease process and treating troublesome symptoms. PN can affect sleep of individuals. It can affect activities of daily living. It could generally make the lifestyle uncomfortable for the individual. So you have reduction in participation in activities that one really enjoys. Now, for controlling the underlying diseases, we can achieve this through eliminating offending agents, which are factors or causes like toxins or medications, or correcting a nutritional deficiency. You're going back, we should be going forward. Mm-hmm. Good. For management of peripheral neuropathy, it's diverse. You could come through medications, through drug prescriptions. We could also go through surgery, depending on the degree of nerve damage. But for today, we're basically concentrating on physiotherapy management. For physiotherapy, we aim to restore or maintain muscle strength, prevent further muscle shortening or deformity, as the case may be. We also work on balance, coordination, and functional training. Peripheral neuropathy is mostly seen in diabetic patients. And with this, we could have a loss of balance, we could have poor coordination, we could also have a deficit in function. Pain relief is also part of our management procedure. PN represents or can come up as neuropathic pain, which is what we see more often, you know, and for this we could use TENS. The TENS is a trans-electrical nerve stimulation therapy, and also we have soft tissue massage. We also have use of space as needed for deformity prevention and contraction. There's also the place of education, which is counseling, we're managing conditions, preventing damage, and of course, provision of emotional support to the caregivers, and also for us as part of the care team. Okay, we're going forward. Next slide, please. Beautiful. This brings us to our case study. Now, for the case study, Mr. Francis will be handling this particular part of the presentation. Thank you as he takes over.
Okay, good evening all. Whatever the time of the day is in your area, please just accept it like that. The case study. This case study was presented as it was a unique case. It was unique because we consider it is not common. And it's a case that is showing bilateral weakness of the limbs, upper limbs, after use of restraint. Studies of such are few and not seen in clinics. And if at all they are seen, they are very, very few. It's a case of a 22-year-old male admitted on the 7th of April, 2001.
2021.
Yeah, 2021. Yeah, well, sorry. It's a case of a 22-year-old male admitted on the 4th of April, 2021. And physiotherapy was called in. Physiotherapy was called in on the 12th of April, 2021. Going through the chart, we saw that what was noted there was that he's being managed for MBD, which was interpreted as minimal brain dysfunction with a long history of recreational use of drug. And the patient was in a private facility. But the patient was restrained on account of aggression and violence. And the restraint was less than just a little bit above 12 hours, according to the history. Please, next slide. Past medical history, knew of significance, past social history. Patient makes use of alcohol and makes use of drugs. We try to look into the drugs that the patient is involved with. And he testified that he uses cocaine, he uses marijuana, and he uses tramadol in large quantity and benzyl. Then he lives with his parents, and he's a college dropout. As of the moment we started seeing him, he was on haloperidol and diazepam. Next slide. On physical examination, patient was not in any obvious respiratory distress. Patient was conscious, alert, and oriented in time, place, and persons. Muscle tone, upper limbs, mildly reduced. The right was more reduced than the left upper limbs. Motor power, is that motor power? Okay. Muscle power, right upper limb, we have 3/5, and left we have 4/5. Talking of gross muscle power. Though we did the charting individually, if there's any question that will arise from that, I think we'll be able to answer it too. Then lower limbs bilaterally, they were normal, nothing. Reflexes, initially on the first assessment, there was swelling. And because of that, we couldn't do the reflexes on the first day of assessment. But subsequently, as the swelling went down, we did the reflexes and it was reduced. Sensation, there was impairment of sensation on the right upper limb, distal 1/3 of the forearm to the hand. There was impairment of some light sensation, but deep was unaffected. As of that moment, we did assessment. The blood pressure was 150/100 millimeter mercury, respiratory rate 16, pulse rate 120, 112 beats per minute, and temperature was 36.7 degrees centigrade. Next slide. On assessment, we discovered that there was pain bilaterally in the upper limbs. And the pain was more around the shoulder region bilaterally. There was swelling of the forearm that extended a little above the elbow, both hands, but it was worse on the right side. We noticed that there were some bruises around the distal 1/3 of the forearm. There was no obvious skin discoloration. There was no open wound. There was no broken wound. Normal skin integrity. Range of motion, actively, it was difficult to assess this because he wasn't, most of the movements, he couldn't do them. But passively, we realized that he had full range of motion and they were pain-free. Muscle bulk. We couldn't assess the forearm muscle bulk because of the swelling. It was difficult to assess it. Though we took measurements to see the difference in the swelling of the muscle bulk between the two upper limbs. Then we also realized that muscle strength was reduced for both upper limbs. Please, next slide. Our own impression is that there was weakness of upper limbs, poor functional use of upper limb, both upper limbs, but it's worse on the right because he couldn't make use of the right upper limb at all. Then impaired sensation for light touch, distal 1/3 of the forearm. Please. The next slide. Plan of care, we decided that, okay, we had to deal with the swelling first. So we employed continuous passive movement to see how we can reduce the swelling. We use cryotherapy and we use elevation positioning to see how we reduce the swelling. We also decided to use PLF technique to see how we can activate the muscles and from there start strengthening them. Then for the pain, we had to use TENS, transcutaneous electrical nerve stimulation, to see how we control the pains he's having around the shoulder and the upper limb and the arm. Then we did have a individualized strengthening exercise program for him. And we also suggested that he should use the arm sling because the hand was just dangling, especially the right arm. So when he stands up to walk, you just see the hand dangling. So we decided that, okay, he should use arm sling to support the right upper limb. Next slide. Next slide. So looking at, please, before we look at the discussion, please, I just want to, it's not there, but let's look at the muscle chart. I'm just going to go through the muscle chart. During our physical examination, we did a muscle chart and we discovered that for shoulder forward flexion, the right upper limb was 2, the left upper limb was 3. Shoulder extension, the right upper limb was 2. The left upper limb was 4. Shoulder in external rotation, it was 3. And the left was 4. Shoulder rotation it was 3 and the right was 4. Elbow flexion, there was nothing at all for the right, but for the left, we found that it was 4. Extension 2 left, 4 and 4 for the left. We were looking at the muscle chart we had. So I'll just continue from finger flexion. Finger flexion for the right upper limb, we said it was 3, and for the left, we said it was 5. Finger extension, it was 3, and for the right and for the left, it was 5. Hand grip, we saw that it was strong. It looked normal for the left, but the right, it was just fair. There was something else we noticed, that the scapular muscles were also affected. There was this stiffness at the left scapula, so it wasn't free to move. And when you try to move it, he complained of pain, severe pain. Then also we noticed that the infraspinatus of the right shoulder was wasted. And so that was what we noticed. So let's go to the next slide, the discussion. Discussion, please.
Is this the right?
Discussion. So looking at all this presentation, sorry, may I mention that we have limitation because we couldn't do certain tests that we consider necessary. So we just have to depend on our physical examination. One of such tests is the nerve conduction study, nerve conduction test that should have been done, but the facilities were not available. So we had to go with what we could see. Now, looking at this case, we now realize that, okay, the rate that the weakness came up, it was too sudden. And we began to question a lot of things. We were like, okay, what could have possibly given rise to this? Could it be traction? Could it be inflammation? Could it be the swelling that must have affected the nerves? Or could it be the toxins from, the drug use that he's involved with, or alcohol? So looking at all this, we now find it very interesting that this is an interesting case. Okay, it doesn't have a typical presentation of complete brachial plexus injury. It's just here and there. We can't say, okay, this is the nerve that is mainly involved. We couldn't just pinpoint anything. So we said, oh, this calls for discussion. So we also understand that we try to look into studies that have been done concerning, matters like this, issues like this, subjects like this, and we couldn't find much. So we said, oh, these deserve to be shared so that we can, have maybe contribution from other people and maybe share our own experience with other people too. That was how we came about making this presentation. Thank you. Over to me.
Yes, thank you for the presentation. That was, can you hear me okay, Alexandra?
Yes, you are good.
It was really, it's a tough case. Let me add a couple questions. I want to point out that your physical exam was excellent, showing decreased tendon reflexes. I find that is the physical exam that really makes a difference. If you get increased tendon reflexes, it's central. If you get decreased, it's peripheral, and you had bilateral, you had particularly on the one side, decreased tendon reflexes. I just want to emphasize that on physical exam, and you did a good physical exam, and you noted that the reflexes were decreased in the arm, which goes along with a peripheral problem. It's the one best diagnostic test, the reflex, to be central versus peripheral. But what a question for you. This is a question regarding treatment. You wanted some suggestions. In Africa or in Yanagwa in Nigeria, do you use any creams? In the United States, they're using creams that have hemp, cannabinoids, that have steroids, that have vitamins, and the creams are pretty important right now on peripheral neuropathies. Even, for example, a carpal tunnel syndrome, a lot of doctors will be putting on a cream that'll have particularly vitamins and hemp. I'm not a physiotherapist in this field, but what is your feeling regarding a peripheral nerve and trying to get nutrients or medications to it transdermally?
Did you have a question?
We didn't get the last question. We didn't get the last question.
The question is this. is there any role for creams with the peripheral neuropathy? For example, let's say you've got a carpal tunnel syndrome. I have one. I saw a doctor and he prescribed a cream for me, which had hemp in it and vitamins in it, etc. But you know, the peripheral nerves are right there. You can get to them transdermally. But is there any experience in Nigeria regarding creams for a peripheral neuropathy?
Yes, we used Voltaren gel initially, and when the swelling went down, we changed over to one of the hot topical gels. What's the name? Neurogesic ointment.
They're NSAIDs. So basically for Nigeria here, for us here, when it comes to the use of creams, more of our focus is on pain relief. Okay, so we tend to use NSAIDs a lot more, or I think steroids too. There's steroids for non-steroidal anti-inflammatory creams, especially for the use of for the relief of pain, primarily. So you can't really, we don't get to use it for transmission or vitamins or thereabouts.
Thank you. Thank you.
Okay. I wanted to also pose a question, but first to thank the speakers for being so kind to join us today and going with the flow, if you will, with the technical challenges. So thank you very much. And I have a question regarding use of physical restraints, as this case exemplifies, versus chemical restraints versus behavioral therapy in Nigeria, and what the current legislation or laws are around that. In the U.S., although it goes state by state, physical restraints are essentially banned, and as are most chemical restraints. So it's not unusual to face a patient who may be combative, might be a risk for themselves or others around them, to face up to the challenge of what to do for someone who requires attention. Again, what limitations or laws are there in Nigeria regarding the use of physical restraints in medical settings?
That's an interesting question, because medically, I'm not really sure there's any particular laws concerning physical restraints, which is, if you go back to the discussion, all right, you would note that from literature, of course, it's not acceptable, just like you stated. I know that in the United States, it's not, physical restraints is out of it entirely. But here in Nigeria, there are no cogent or concrete or visual laws stating categorically that you can't use physical restraints. You know,
I'll just interject while we await the return of the speakers. If anyone else has a question that if and when they come back on to pose, feel free to put that in the chat. I'll keep an eye on that, and we'll see where we go with our connectivity.
okay.
Let's give them a few more minutes to come on back, hopefully. There we go.
Can I ask a question that's be open to anybody? What about the empiric use of the different vitamins? Just using thiamine, using pyridoxine, vitamin B6 and so on. But generally, are these to be given in these situations, or how do people with a peripheral neuropathy, let's say due to trauma like we have here, is there any role for giving, because the neurologist really very big on different vitamins, Is Ellen Bernstein on the talk right now? Ellen? This is Ellen's forte, B1, B6, etc. But any comment regarding empiric use of particularly thiamine, pyridoxine, those agents from anybody, any experience?
Yeah, there's
Yes.
sort of a I'll let the speaker continue.
Oh, there's Ellen. Ellen, please, go ahead.
Okay,
Well, there's sort of empirically we use a B complex. It's more than pyridoxine, thiamine. There's certain niacin component. There's a riboflavin. They all have a nerve. They all involve peripheral nerves substantially, so that almost empirically you want to put people, whether it's an alcohol neuropathy or traumatic neuropathy, on a high B complex formula. It seems to speed healing. It also seems to reduce neuropathic pain. Mechanism for that's a little more complicated and has to do with the serotonergic effect of pyridoxine specifically in terms of increasing serotonin, lowering pain symptoms. So although, a traumatic peripheral neuropathy is a little slower to respond, most of the metabolic ones, particularly alcohol, respond quite well to a high dose. Now, high dose, I usually consider there's an over-the-counter vitamin called B50. It's 50 milligrams of each of the B vitamins, and you take it once a day in the morning only because it'll keep you awake. The RDA for most of these vitamins is 1 to 2 milligrams, so 50 is a substantial overdose by usual criteria, but well below the potentially toxic levels that you have to worry about. So that's my usual take. Respond to your previous question, Jim. I'm not a great fan of topical creams, other than they do offer some pain relief, but they don't really change healing rates, at least in my experience.
Ellen, question. You said not to take vitamins at nighttime. They keep you awake. I've never heard that.
B vitamins. Why do you want to try it? Take a B vitamin before you go to bed. See how well you sleep. You won't.
I've never heard that.
Yeah,
Greg, have you ever heard that? I mean, that's very good information, and I've never heard it. I guess I'm not old enough.
They're stimulants. They're very nice in the morning. B vitamin, a cup of coffee will keep you up all day.
Did you say the vitamins will keep you to sleep or won't keep you to sleep?
They will not let you sleep. They're actually stimulants.
Okay.
Larry, did you know that?
Oh, no.
I see also Dr. Dugas has a question, hand raised. So Dr. Dugas.
Yeah. Why are the people who most need restraints in facilities which have the fewest resources to provide behavioral therapy to get them calmed down and deal with it? I mean, this is just one of the issues, as a geriatrician. I've had to treat frontotemporal dementia, which can be just absolutely horribly violent and wild. And fortunately, because they're mostly psychotic, we could use chemical restraints. But this person had hurt people, and we have these laws now, or there's strong guidelines. You really have to approach this carefully, and in facilities least capable of providing the behavioral reorganization are the ones, of course, where these patients are, whether it's an overcrowded psychiatric facility or whatever. How I'd love to see a program on how you do this and what really works, because I've struggled with it. I'm no longer in practice. I'm glad I'm not because of this. The second comment I would like to make is I had absolutely no idea until I visited Brazil that leprosy was a major cause of carpal tunnel syndrome at least in Brazil, and it was diagnosed by a father-in-law of a former Rotary Exchange student several times a year, just from the nerve conduction study. It was fascinating. And I've seen lots of carpal tunnel, mostly from various overuse in industry or on computers and whatever. So, but how did they get this person calmed down in Nigeria? Did they have to use chemical restraint? I think I've dealt with prisoners who would come to me in chains from Angola, the rather disreputable prison in Louisiana. And they were kind of interesting, and I wasn't thrilled to see them without chains, to be honest. So just throwing it out. Well, Jim, you get prisoners from the various penitentiaries you've had.
You know what we do now. This is what we do is we give Haldol 2 milligrams if it doesn't work in 15.4, if it doesn't work in 15.8, if it doesn't work in 15.16. I've never had to go above 16, and no one has died of that.
Chemical.
But
That's
you
chemical.
got to stop them. You got to stop them. They're going to hurt you. The last one I had like this threw an oxygen tank at me, and I ducked it and went through the wall. So you've got you've got to be careful with these people. But we use the haloperidol approach, which is readily available almost anywhere in the world. And it's you give a dose, double it in 15 minutes, and you stop them all. And I hate to say that, and I haven't had any deaths. The one trouble with haloperidol is it can produce VTAC, arrhythmias, and so on, rarely. But it's nice if they're being monitored. So if you see if there's a problem, you stop. But these people, you can't get anything into them. You have to use IM. You can't do it any other way.
Yeah, but the problem is in nursing homes, they won't do it. They get dinged for it. That's the whole issue.
You've got to protect
You're in an
your
acute
nurses.
situation where there's safety issues. Most of these start occurring in chronic units that are understaffed, with least educated people, and chemical restraint is the easiest thing to do. But you can be highly criticized for it. I mean, I don't think there's a happy medium.
John, you've got to protect your nurses. I've seen nurses have their faces smashed in by a knee from one of these individuals.
Frontal temporal dementia put a nurse in the emergency room. Yes, that's I understand. And we were criticized heavily for loading him up.
You got to take criticism to take care of these people. How about some other input on that? That's what you got to do something.
How did they get this guy calmed down in Nigeria?
What did you say?
Question again, please.
Sorry, we didn't get that. Repeat your question.
How did you get the agitated patient to cooperate? Okay.
He was already on medication before we were called in, and when we were called in, his aggression has been controlled. So he cooperated, and of course, we allowed him to understand that we are here to be of help to him. He was no longer restrained, and he was even worried that his hands were not working, that when he came, his hands were working, so he was cooperating.
So you had a psychiatric diagnosis to be able to use the medications, and he did respond. So, I mean, I think is important.
Yes.
Yes.
Just delirium, who knows? Usually that's somebody causing it with meds or something. So, okay, good.
Another question. In Nigeria, given the fact that quite a bit of the population is rural and does not necessarily have access to physical therapy or physiotherapy facilities, are there examples of how patients might be managed remotely using telemedicine platforms for managing not only injuries like this, but essentially delivering physical therapy, physiotherapy remotely in a telemedicine environment? Is that done in Nigeria?
No, we're
So yeah, essentially how individuals who might be rural, let's say that they've been seen in a facility or an emergency room, a medical setting, they return to their home in a rural area away from a physiotherapy setting. Is telemedicine used in Nigeria to help bridge that gap?
I would say that the use is rather poor, primarily because, of course, like we're experiencing right now, there are network challenges. And then for those in the rural settings, accessibility to facilities like telephones is one major issue. So that's not something very high up in medical care right now.
Okay. All right,
Alan,
we have
could-
about
yeah.
a few minutes remaining, one or two more questions, and we'll.
Hey, I have a
ready to
question. I have a question. It's Larry Falcon. I was offline there for a minute, but have you guys talked about B12 and peripheral neuropathy? And how important is that in elderly people? I was recently told that you don't have the right factors to absorb B12, and that can lead to peripheral neuropathy, which can lead to falls. And you may have already discussed that, or if anybody has any comments about that, I'd appreciate it, especially our friends in Nigeria.
No, the use of B12 is on here. For this case, he was on vitamin B12, so it's being used for the treatment of peripheral neuropathy. However, I think it works better at the early stages than much later. This is my opinion anyway, but it's being given. It's a drug that is being prescribed for peripheral neuropathy here.
Alan, any ideas?
Well, B12 is a tough one. It's age related to a great extent. And if you've got a younger population, I think most of Africa has a younger population than we do here. B12 deficiency is less likely in that kind of setting. We see it here because of age-related inability to absorb. We see it because of a lot of use of over-the-counter antacids. So it's not even on the medical record. And once you block acid in the stomach, you block your intrinsic factor, effectively producing a B12 deficiency. So a lot of the falls in the elderly are in fact B12 related, and in fact are in a sense self-induced, not by diet, but by treating their gastric reflux primarily. But B12 is readily available in our diets. It's really hard to have a B12 deficient diet.
Will that
Alan,
keep you
could
awake
use
at night?
B12 levels?
B12 levels are generally good. Unfortunately, the lab sets the normal at the level needed to produce macrocytic anemia, not the level needed to produce neuropathy. So the level to produce neuropathy is anything below 400. And the level to produce macrocytic anemia is the level below 200. So if a patient has a level of 300, the lab says it's normal. And if you don't look carefully at the number, but just look at their normal, abnormal markers, you're going to be misled and you're going to miss the neurologic problems of B12 deficiency because they're focused on the macrocytic anemia.
Amazing. Good information.
Dr. Duval?
B12 keep you awake?
Couple of things. It's really important if you have a neuropathy, in my opinion and experience, that you order a methylmalonic acid level in an American lab at any rate to give you some idea of whether they really are vitamin B12 deficient. And it seems that the neuropathy with B12 is very different and seems almost like a different disease than the anemia. And I have seen people with one, not the other. And I wasn't totally aware that actually 400 and 200 were cutoff numbers, but there's a significant possibility for error in the testing process. The second thing is that I love a 150 CPS tuning fork. And B12 classically produces posterior column neuropathy. And if it isn't syphilis, it may well be B12 in somebody who's older. And you can find an awful lot of things, positional changes in the toe. You can push the toe up and down and pull it actually. And but the tuning fork is faster, quicker, and you actually identify all kinds of neuropathy, and specifically the posterior column you get with the B12. And it's an issue. Metformin, a classic drug used constantly, recommended as a first drug to treat type 2 diabetes, will cause B12 deficiency. So be aware of that.
Yeah, and in this case, on this excellent dialogue about comorbidities and predisposition to vitamin deficiencies, B12, this case, this young man with a history of alcohol overuse and drug use, etc., may have, premorbidly, if you will, have been walking around with a significant B12 deficiency. And it took 12 hours of wrist restraints to kind of throw him over the edge. And, so great conversation and observations about vitamin deficiency and treatment thereof. Thank you very much. We're down to the last few minutes. If we don't have any other questions, I'll love to take one or two more, and I just want to make sure we finish on time. And again, thanking everyone who attended this morning and our staff for supporting this excellent presentation by our speakers who were so kind to join us and to go with the flow again.
Can I say something?
Yeah.
Go ahead.
All right. This particular patient, last week we put a call to his father. We wanted to see how he was doing because after 7 sessions of physiotherapy, he absconded from the hospital. He ran away. And by the time he was brought back, 2 days after, he was brought back to the private hospital. We went back to see him. His father said he doesn't have money to cater for physiotherapy anymore. Here they believe a lot in local masseur, so he was calling him a local masseur. So we wanted to see how he was doing, so we put a call to his father. That was last week, and he had to allow the boy to come to the hospital, Federal Medical Center here to see us. Funny enough, I think the boy is just left where we ended with him. There was no improvement. It was just where we left him, that is where he is. And we were trying to encourage him that he should come to physiotherapy department to continue his treatment. But he said that is subject to his father making the fund available. But we will see, because I was talking with my colleague that this is the case we should follow to the end. But we'll see how it goes.
Maybe we'll
Thank you for that. Thank you for that follow-up. That's excellent. Okay. Unless we have any other comments or questions, thank you again all for attending this morning. We will be having, for those who are part of the Global Offsite Care group, a meeting to continue after this session. So for those of you in that meeting, please stay on. And again, thank you all for attending, and special thanks to our speakers. This was wonderful. That's always a pleasure to be part of this, and also to meet folks from around the world who are out to make it a better place through healthcare. And thank you all again.
Thank you, everyone. Thank you for coming. Thank you for the presentation.